Hello everyone, I hope you had a good weekend. Today we are going to cover chapters 4 and 5. We're going to start with chapter 4, which is medication administration. So as far as the roles in medication handling go, the circulator is going to obtain the correct medication according to what's on the preference card. They're going to deliver the medication to the sterile field using aseptic technique. And they're going to document all medication that is used from the sterile field. They're also going to, in addition to these things, they're going to inspect the containers for integrity. They're going to be checking expiration dates. And like I said before, we're going to make sure that we are always maintaining sterile technique when transferring. And that of the surgical technologist. They're going to identify and accept the medications from the circulator. They're going to label the medications immediately. We're going to pass the medication to the surgeon as it's requested. And when we're passing, we need to make sure that we are clearly stating the name and the strength when we are passing it to the surgeon. And remember that if there is no identifying label on the medication, then we throw it out and we get a new dose. Most medications that we use on the sterile back table are clear. And so it is very difficult once those are all poured out to figure out which one is which if they aren't not labeled. So labeling and identifying is crucial. You will hear that a lot throughout this chapter. Okay, now we're going to go over the 5 rights of medication administration. These have been established to help avoid medication errors. And they base it on these 5 rights. So we have the right drug, which is basically asking what drug is required. We have right dose, how much of the drug is required and in what concentration. Right route, how will the drug be administered. Right patient, who will receive the drug. And right time, when will the drug be administered. So for the right drug, drugs that are routinely used in procedures we've gone over before are listed on the preference card. You need to be sure that the preference cards are accurate and the spelling should be correct and the strength should be correct of the medication. Cards should be updated as needed. This usually is done by a specified 1 or 2 people on the operating room team. They are usually in charge of the cards. Excuse me. All right, some medications sound very similar. For instance, Depo-Medrol and Solu-Medrol sound very much the same. So we always want to make sure that we are clarifying the name of the drug. Some may also have similar spellings, such as Tobrex and Tobradex. 2 different drugs, but they're spelled quite similar. So we're always going to make sure that we are clarifying the name of the drug. Never be embarrassed or ashamed to admit that you're not sure. Okay. The Institution for Safe Medication Practices maintains a list of commonly confused drugs that your facility should have on hand for you to be able to look at. And again, once delivered to the sterile field, make sure that we are carefully identifying and labeling clearly and immediately. Right dose. The dose of a medication is a factor of its volume and its concentration. Okay, there is page 6, Insight 1.2 for review if you need it from chapter 1. Some medications may come in a number of different concentrations in the same volume. Heparin is a good example of this. It may come in 10 units per ml or it may come in 100 units per ml. An example of when this would be used is during the insertion of a venous access port. Different strengths are needed, the 100 units and 10 units, but as you can see here, they're used at different times in that procedure for different reasons, and the difference in those strengths is tenfold. So that is where our proper labeling comes in again, and ensuring that we are stating what we are handing the surgeon when we hand it. So this is heparin, 10 units per ml. Or 100 units per ml. We're saying that to the surgeon, so that serves as a final safety check that we are giving the correct medication and the correct dosage. Okay, right route. Most medications in surgery are given by IV. by the anesthesiologist, but some may be given topically or by injection from the sterile field as well. Different routes may require different preparations and different concentrations. And the preference card should clearly state the route and form. However, reading the medication label should always be a #1 priority as well to ensure that we are using it properly. For example, 1% lidocaine with epi may be used for local anesthesia during a breast biopsy. The administration route may not be clearly stated on the preference card because this drug is formulated for injection. This is where reading that label, medication label, would come in and be key, especially if a member of the team is unsure or they are a newer nurse or tech that aren't aware that this is an injectable medication. That's where reading the label and knowing how to understand what's on there comes in. Another example is the middle ear procedures. These are two very different strengths of epinephrine are used, especially in tympanoplastics. We can use epi 1 to 1000 with gel foam for topical, and we can use it with local diluted with epi for injection over a large area. Both are used for vasoconstriction, but very different routes and very different strengths. And both solutions are clear. So that is another example of where we want to make sure that we are reading and labeling correctly. Page 52, Insight 4.1, has an excellent story about what can happen when epinephrines are mixed up. It's unfortunately not a great story. It's not a very happy ending, but it is a very interesting read. I would highly suggest that you look into that. Okay, next we have the right patient. All surgical patients are properly identified before being transported to the OR. Surgical safety checklists are used to ensure the correct procedure is performed on the correct patient. Patient allergies and a history of medication complications are also listed. And a surgical timeout is always performed before an incision is made. Okay, so those are some more safety checks that we are going to use to make sure that we have the right patient. Then we have the right time. The surgeon or the first assist administers all medications to the surgical site. This prevents the majority of medication timing errors. The purpose of the drug often indicates the timing of administration. So for example, 1% lidocaine with epi listed on the preference card for local will be administered before incision. However, 0.5% bupivacaine with epi may be given as post-op pain control, and it'll be given at wound closure. Some routine medications are obtained during case setup and labeled and then passed to the surgeon at the appropriate time. An example of this would be contrast media. So you may have hypake that you've gotten at the beginning of the case. You've drawn it up in your syringe, you've labeled it, and now it is there and just waiting for your surgeon to be ready to use it. As long as it's labeled, that is absolutely fine. So here's just a couple of examples of a couple of different vials of medication, and it's just to illustrate and give you guys a visual. As you can see here, all are clear. There's no color to any of these. You can see that it's not for epidural or caudal use. It is for injection. It lists how much epinephrine we have. It lists the strength, okay? Same over here. The name, the strength, the concentration, the volume, okay? All right, next we have documentation. This is a bit of a bonus right. Medications given from the sterile table must be documented in the patient record. The circulator documents all meds given to the field, and the surgical tech will verbally provide a final amount of all meds used to the circulator for documentation at the end of the case. Okay, so we'll be using locals and different kinds of medications repeatedly throughout procedures. So we need to make sure as a surgical tech that we are keeping track of what is being used and how much. All right, next we're going to talk about medication identification a little bit. Both the scrub and circulator are responsible for correctly identifying medications. And following a specific series of steps reduces the risk for errors, and you can see these in box 4.3 on page 53. But the circulator obtaining the meds reads the label and checks packaging integrity. That is the first step. The circulator is going to read the label aloud to the scrub, and they're going to turn it around so that the scrub can see it and repeat the information aloud back to them. The scrub tech is going to accept the medication, and we're going to, of course, label the medication containers immediately. All right. So let's talk a little bit about how we are getting these medications onto the sterile field. Again, sterile technique is always used. Different containers require different methods of delivery. The most common that we're using in the surgical setting are glass or a plastic vial with a rubber stopper encased in metal. It's covered with a plastic cap, and what we're doing usually is we are popping off that plastic cap, we are drawing the medication up into a syringe through a hypodermic needle, and then delivering it to the back table. If for some reason the nurse does not have a hypo and syringe to draw up and deliver the stuff, then the scrub tech will be able to draw up using a two-handed technique, which we will learn about in class. First, you're going to draw some air into the syringe, insert the needle into the vial, and inject that air. That creates a vacuum for the meds to go into the syringe faster. And we're also going to use a larger gauge needle when we are drawing up meds, such as an 18 or a 20, usually an 18. Okay, we also have decanters. These are disposable pour spouts that are used to dispense fluid bags. We also make them for vials and bottles as well. Excuse me. These provide a greater margin of safety because they increase the distance between the circulator and the sterile field. Most facilities, almost all of them, have them available. You won't always see them used, but they are there for use. Okay, next we have glass ampules. These are glass containers that are sealed and they have a narrowing at the neck. They're broken at the neck and the medication is drawn into a syringe that way. We always want to make sure when we are breaking these open that we're using some sort of a lap sponge or a 4x4 or a towel, anything that's going to protect our hands if we're breaking them open from the sterile field, because we do not want to cut ourselves on that glass. And once we've used that sponge to open it, then we're going to get rid of it so that any glass particles don't end up on the field. They stay with that sponge and leave the sterile field. Sometimes the ampules are able to be opened sterilely onto the back table and the scrub tech will open them like I was just talking about. A good example of that is bone cement. Those ampules will be opened onto the back table and we will open them ourselves. Okay, here's just some visual examples for you to see. As you can see, this one is for a bag and is a long decanter. This one is for a vial. These are the vials that we were talking about. So we could pop this red top off and use a syringe and needle to draw up the medication and then squirt it onto the field. Or we could use this vial decanter, in which case we'd just pop off that red top and stab this through the rubber stopper here. And this is an example of what an ampule would look like. Obviously, we have the bone cement ones that could open onto the back field that are much larger, but it's the same concept. You can see where this is narrowed right here at the neck. We would just take a sponge, grab a hold of that, and snap this off right here at the neck. Okay. Okay, so as we said earlier, most drugs used on the sterile field are clear in color. This is why we label, and this is why we label immediately. And it's also a JCO standard. But once the medication is on the sterile back table, it needs to be labeled immediately. We're going to label both the storage container and the delivery container. So that means we're going to label both the medication cup that it's in and the syringe that it goes into. Labels they can come pre-printed. These are the most accurate. However, a sterile marker and blank labels may also be used. We just need to make sure that when we're using that route, we are writing legibly We are writing clearly, and we are being very complete in what we are putting on the label. Okay, we also want to make sure that when we label that place that label on the syringe, we are placing it opposite of the volume markings. You don't want to cover those up so that you can easily track the amount of medications that you're using. And it's important to note that improper or inadequate labeling of medications on the field can be considered negligence. So we need to make sure, not only to protect the patient, but to protect ourselves, we are labeling our drugs. It may happen at some point that someone comes in to relieve you, either for a lunch break or for the day. They need to be able to know what's in those containers as well. So labeling is crucial. Sometimes the rapid pace in surgery can make labeling immediately a little difficult. However, there is absolutely no problem with slowing things down and pausing for a minute to make sure that those drugs are labeled. And never be embarrassed about confusion. If you relieve somebody and you're not sure what's what, always admit that either you don't know what a certain substance in a container is, or that you're not sure of what anything on the table is. Always admit error immediately so we can fix it. And never be ashamed or embarrassed to admit confusion either. Okay, so here are just a few examples of those labels we were talking about. This right here on the left is usually going to come in your surgery pack. It's got a sterile skin marker, a sterile ruler, and these are hard to see on this white background, but these are blank sterile labels. So we can absolutely fill these out and use these perfectly acceptable as long as we are writing legibly and clearly. In the middle here is an example of the pre-printed labels, and this is just facility-based. Some have them, some don't. And over here is a good example of labeling both the storage container, which is our medication cup, and measuring our syringe, labeling our syringe, making sure that we leave the volume markings clear of any stickers so that we can see how much we're using at a time. All right, so when we're handling our medications, it's vital to read the preference cards regarding what the surgeon wants for medication and how he wants them prepared. We're also, as I said before, going to be sure to verbally confirm the medication being delivered to the surgeon, especially if it's a mixture. So we have diluted 2 locals together. This is 1/4% epi and 1% epi, are 1-to-1 solution, or here's 60 cc's of hypake that we've diluted with 20 of saline. We always want to make sure that we are letting them know exactly what is in that vial that we are that syringe that we are handing them. Okay, some medications may require reconstitution at the sterile field before being used. Some things such as our Ancef powders and things like that may need reconstitution with liquid. And we're always going to use special caution, obviously, when handling controlled substances. We want to make sure that our label and recording is clear on those. So here, guys, is an example of a preference card that you might see out in the field. This is actually a really good one. We have the doctor's name, the procedure, what position they're going to be in. Here's their glove size. It says that they're right-handed. Let us know what kind of equipment he wants to use for this procedure. The supplies, instrumentation. This is a list of the sutures that he's going to use and on what part he's going to use them. That's nice. Dressings, what we're going to use, triple antibiotic ointment, Telfa, 4x4 and tape. We're going to shave and use a betadine scrub for the skin prep. And down here is a list of medications. It says he wants 0.5% bupivacaine with epi. He wants to use that in a 10mm control syringe, which we will go over. And he likes a 25 gauge needle. So those are all things that we'll cover in a minute, but there's a good example of what we would see as routine on a preference card. All right, so syringes are used routinely in surgery to draw up medication and measure. They have three basic parts: the barrel, the plunger, and the tip. Medications and syringes are measured from the innermost edge of the rubber tip on the plunger, so that's how we know how much we've used. And the most common sizes of syringes in surgery are going to range from 1 to 60 milliliters. We have 1 milliliters, 3, 5, 10, 20, 30, and 60. Those are usually our most common. The most common type of syringe used in surgery is the Luer lock. This has a screw-on tip at the end that we can secure hypodermic needles onto. So those are the most commonly used, are our Luer lock syringes. We also have plain and slip tip syringes. Those are used for relatively specific purposes if we use them at all. And then we have some specialty syringes like 2-Bex syringes, the control syringe, and a dual syringe. These are all different types of things. The 2-Bex ones are metal. They're used for carpule injections. Carpules are just glass tubes with a rubber cap. They're penetrated by a needle attached to the syringe. They're not used very often anymore. And the dual syringes, these deliver 2 meds that mix at the tip. This is usually going to be with our fibrin sealants. So like our DuraSeal and things like that for spine cases. Okay. So here are some examples of those. This up here is going to be our 2-Bex syringe. So our carpule would go right in here. There's a special little needle that will just penetrate the rubber cap of the carpule, and then we can attach a needle down here. So very old, very rarely used. This down here is a couple of different things actually. This is a Luer lock syringe. As you can see, it's got that screw-on tip where our needles are going to go. This is a 10 millimeter syringe, so it's most commonly used for locals. And this is also what we were referring to as a control syringe. So as you can see, rather than like over here, the traditional looking syringe, this one has finger grips and a thumb grip to offer more precise injections. That's what those are for. So this is a control syringe, but it is a Luer lock as well. This one here is one of the dual delivery syringes. So our fibrin glue and our fibrin gel are going to be kept separate until they come together at the very tip, and that is where they're going to come together and work to make that seal. So these are kept separate up here in the syringe itself because as soon as they do mix, they start forming that seal. So we need to keep them separate until we're absolutely ready to use them and place them on the tissue. And this over here is an example of a slip tip syringe. So you can see it's got a different tip to it. We do not get hypodermic needles on here. So these are usually used for some kind of irrigation and aspiration purposes. Okay, and you can see here then too, here is our plunger. Here is our rubber stopper, and then this obviously is our barrel. So right here we can see this is a 10 cc as well. According to the bottom line of the plunger, which is right here, it's at the 2, so we've used 8 cc's of whatever was in there. That's how we read those syringes. All right, last but not least, we're going to talk about some hypos. These are used to draw up and administer drugs as well. They also have 3 basic parts: the hub, the shaft, and the tip. They vary in diameter, which is their gauge, and length, which is usually delivered in inches. And it's good to note the larger the gauge, the smaller the diameter. So for example, an 18 gauge needle is going to be much larger than a 27 gauge needle. And the most commonly used size in surgery range from 18 to 27 gauge, and the 1.5 inch is the most common length of hypo that we're using in surgery. We will also use 5/8 of an inch for the more superficial injections like in hands, carpal tunnels, fingers, things like that. And we do also have the 3-inch lengths. These are known as spinal needles. These are used for intrathecal injections, maybe injections into joints. We will use them to find our place for a camera or incision when we're doing arthroscopies. And the spinal needles are also quite often used for aspirations and cysts and things that are deeper in in the body. Okay, so here is a visual on those hypodermic needles. They are usually color-coded, and it is usually universal. So pink is always going to be our 18 gauge needle. And as you can see, the 18 gauge pink needle compared to this 27 gauge blue needle here, you can see the difference in the diameter. So that gauge is what we were talking about earlier, where the larger the gauge, 27, the smaller the needle. Here's a 27, here's an 18. So there's a good visual on the difference between those. Okay, and like we said before, there are 3 parts. So we have the hub, which is right here. This is the part that is going to screw into our lure lock. We have the shaft here, and then we have the tip. They are pretty, like I said, universally color coded. So 18 is pink, our 22s are gray, and our 25s are orange. Okay, then we have the 27, which is blue. Okay. And lastly, I want to talk a little bit about sharp safety. So standard precautions state that needles should never be recapped. Once they are used, they should go into your sharps container and stay there. However, the use of syringes and needles are quite often repeated during surgery. We're using them multiple times. So prevention of injury when the needle is not in use during a procedure, recapping is a necessity for us. And there is a way to do that to prevent injury. The surgical technologist, you should use a one-handed recapping technique, which is basically where you scoop the needle or the cover back onto the needle and then use your Mayo stand to secure that cover. And we'll watch some videos on that in class so you guys can see a good demonstration of it. But one-handed recapping is what we are going to do. Okay, and with that, guys, that brings us to the end of Chapter 4. So if you have any questions, please leave them here at the end. And we'll go through Chapter 5 as well, and I will see you guys in class today. Have a good one.